You are listening to Medscape's In Discussion series on breast cancer and HER2, a podcast where thought leaders and clinical experts share their diverse insights and practical ideas for optimizing patient care. This series is hosted by Dr. Kathy Miller, Valve Lentero Professor at the Indiana University School of Medicine, Department of Medicine, Hematology Oncology Division. Relevant disclosures can be found with the episode show notes on Medscape.com or the Medscape app. The topics and discussions are planned, produced, and reviewed independently of advertisers. This podcast is intended only for you as healthcare professionals.
Hi, I'm Dr. Kathy Miller. Welcome to the Medscape In Discussion podcast series on breast cancer and HER2. Today we're going to tackle the topic of CNS involvement in HER2-positive breast cancer, trying to understand both the biology and managing patients with this problem. I am so excited to introduce you to Dr. Nancy Lin. Dr. Lin is professor of medicine at the Harvard Medical School, and she also serves as the associate chief in the Division of Breast Oncology at the Dana-Farber Cancer Institute in Boston, Massachusetts. Welcome, Dr. Lin.
Thank you for having me.
Now, I know CNS involvement in breast cancer in general, and particularly in HER2-positive disease, has been a passion of yours for a number of years. Can you first help us understand the scope of the problem? What proportion of patients with HER2-positive disease develop CNS metastasis?
So, when we look at patients who have early stage breast cancer, fortunately, it's relatively uncommon, although we do see it. And so, in the Catherine study, which looked at TDM1 post neoadjuvant therapy for patients with residual disease, about 6% of patients developed isolated CNS recurrence as their first site of recurrence. And that doesn't sound like a lot, but it was actually more than half of the recurrence events that occurred in the trial. If we look at the metastatic setting, we do see that over time, more and more patients develop brain metastases. And so some of the older estimates are that up to half of patients will develop brain metastases over the course of their lifetime. And my colleague Sarah Salmons has recently done an analysis of the Flatiron database. So this is real world data. There are over 18,000 patients with metastatic breast cancer in that database. And if you look at patients with HER2-positive breast cancer, around 10% have brain mets when they're first diagnosed with metastatic disease before they start first-line therapy. And by the time patients get to third-line therapy, about a third of patients have brain metastases in addition to the patients who had it at the outset. So we are definitely seeing it, and we're still seeing this in the modern era.
So, do we know why CNS metastases seem to be more common in the HER2 subtype than in other phenotypes of the disease?
We don't fully understand this. It does seem that there is truly a biological propensity. It's not just a matter of the brain being a sanctuary from trastuzumab, that there really does seem to be some biological reason why HER2 predisposes to brain metastases, but we don't fully understand beyond that what that's mediated by.
I remember a study that one of my former pathology colleagues, Dr. Sunil Badvi, looked at trying to answer that question. And they were able to find some genetic patterns that predicted early brain metastasis. So, those patients you mentioned for whom this is a first site of metastasis versus those where it's a very late phenomenon. But trying to look at CNS involvement or not really just wasn't successful.
It's interesting. That's exactly right. We've also tried doing this, and like ER status, ER negative status predicts earlier brain mets versus later in the HER2 positive space. But again, many people have tried putting together signatures that predict CNS relapse, but when you try to validate them for the ever versus never question, it turns out that they don't validate.
Do we know if this is getting more common over time? That there have been dramatic improvements in management of the systemic disease. Does that mean we're seeing more patients with CNS involvement?
I think if we compare to the pre-trastuzumab era, the answer is yes. Remember that before trastuzumab came around for metastatic HER2 positive disease, the median survival was only about a year and a half. And so patients were not often living long enough to develop brain metastases. I think that's obviously different now in the HER2 positive space where patients live for many years. And one of the things that has been sobering when we've looked at the rates of CNS metastasis over time is that we don't really see a plateau. Patients develop brain mets in the third line setting, in the fourth line setting, in the seventh line setting, the 10th line setting. So it seems to be quite different than small cell lung cancer, where you see these early peaks. And then if you make it past the early peak, patients are often okay. This really seems quite different. Patients remain at risk really long term.
So this feels a bit stochastic that if you imagine you have microscopic CNS metastasis, the longer you live, the more likely they perhaps grow to the point where we can detect them.
Yeah, and I wonder if that may be part of why it seems to have been easier to identify potential signatures of early CNS relapse versus the late, ever versus never question, because I think molecular features may or may not end up predicting stochastic events, but they may predict early biological predisposition.
It reminds me of a study that some of my colleagues did in the anti-angiogenic therapy era, where we compared the rates and the survival of patients with asymptomatic CNS disease just found on screening with a cohort who had presented with symptomatic metastasis. And their survival appeared identical. And it really suggested a stochastic phenomena of if the Mets happened to land in an area of important function, you presented with symptoms. Otherwise, you might be found on screening.
Yeah, I actually cite that paper quite frequently because obviously this question about screening comes up all the time, both at meetings and tumor boards and with patients. Should we be screening patients with metastatic disease with serial brain MRIs in the asymptomatic situation? And your study and others have not shown survival differences associated with screening. I think that some of the other endpoints that are important to patients are difficult to discern from retrospective studies. And so a number of people, including my colleague Eyal Azer at the Brigham, but also colleagues in Canada and South Korea, have launched prospective screening studies where additional endpoints are collected, including neurocognitive outcomes and functional outcomes. And I think those studies are very important because obviously there are outcomes that are very important to patients beyond survival, but it's really hard, you can't go back in a retrospective study and assess neurocognitive outcomes. So I think those studies will be very important to try to get at this question in a more comprehensive way.
I would love your thoughts on the surveillance and the screening because I personally have PTSD from the screening, from the anti-angiogenic therapy. It's a very different era, and our systemic treatments have come a long way. So the results might be very different. What was so sobering for us is that, as best we could tell, none of the patients with CNS metastasis that we identified developed symptoms. Now, all but two of them were radiated after the CNS metastasis were found. So, what's tough to know is how many might have developed symptoms if they had not been treated. But it appeared that they all died from progression of their systemic disease, not from the CNS metastasis. And because that then limited their therapies, because so many trials excluded patients with CNS disease, it was really hard to feel like we helped those women who we found things in.
I feel the same way, and I have the same PTSD because I also screened patients for the various bevacizumab trials and also many of the HER2 trials, particularly at the beginning, also screened for brain mets, and those patients were unfortunately excluded from the trials. So I hear you. I think one of the nice things about these ongoing studies is that they do separate out subtypes because I think the answer to the surveillance question may be different, right, in patients with HER2 positive disease versus those with triple negative breast cancer, where post brain met survival is very different. And Dr. Azer, part of the motivating data for this prospective study was kind of a natural experiment where they looked at patients with non small cell lung cancer versus those with breast cancer and the presenting features at the time they developed brain mets, as well as the treatments they received. And it's a natural experiment because the lung cancer patients are generally surveyed and the breast cancer patients are not. Obviously, it's two different diseases. What he found was that the patients with lung cancer tended to present with fewer lesions, smaller lesions, less likely to need whole brain radiation, et cetera. And so that's part of the motivating idea behind this prospective study. And again, the study actually, the way it's designed, there's a separate cohort for triple negative patients because the questions and the value is going to be quite different potentially in that group of patients compared to patients who potentially have longer survival after brain mets like the HER2 positive.
Well, there certainly have been many more advances and improvements in treatment and extending overall survival for patients with metastatic HER2 positive disease and triple negative. If there is a group where surveillance might be helpful, whether it's improving survival or preventing symptoms, it does feel like the HER2-positive group might be the sweet spot where that would be useful. But I won't be doing it till you show me data that it works.
I'm with you.
We've mentioned the blood-brain barrier a couple of times, and I also spend way too much time with radiologists who point out that the edema we see around the brain metastasis means the blood-brain barrier is not functioning very well. Is it really still accurate to talk about it as a barrier in that way?
I kind of distinguish the blood brain barrier and the blood tumor barrier, and also what's the goal of treatment. So, the reason we give gadolinium is because the blood tumor barrier is disrupted and tumors enhance because the blood tumor barrier is disrupted and gadolinium can get out. So, we know that the blood tumor barrier allows molecules in that the normal blood brain barrier would not. And we know this both for small molecules, so dabrafenib, which was developed for melanoma, purposely engineered such that it would not cross the blood-brain barrier because they were worried about the toxicity. And lo and behold, it turns out that, patients with brain metastases did respond, not with prolonged responses, unfortunately, but they did have transient and very convincing responses. And the same is true of lapatinib, which we always sort of think of as crossing the blood-brain barrier, but actually in animal models, if you look across the intact blood-brain barrier, without a tumor in place, you don't actually see a lot of lapatinib crossing through the intact blood-brain barrier. And obviously for the antibody drug conjugates, that's even more true because they're very large. But of course, we now know that many of these drugs, including drugs like TDM1 and TDXD, do lead to CNS responses. So enough is getting in that we're seeing a biological effect. I think the other question really has to do with prevention and whether drugs that get through the intact blood brain barrier better are necessary to get the optimal prevention effect. And if we look at lung cancer, ALK positive lung cancer, for example, the more the CNS penetration of the successive generations of drugs, the more we're seeing a real CNS prevention effect. And one of the things that I wonder about the Catherine trial, which was that post neoadjuvant TDM1 study, where there was not a difference in the CNS relapse rates between the two arms, is maybe we need something that gets in better in the prevention setting. We'll have to see. I mean, it is possible that just by better control of systemic disease, you don't have seeding to the CNS, and so you don't need that CNS penetration. But there's micrometastatic disease already pre-existing in the brain. You would think that the drugs have to get in order to prevent it from growing out.
Prevention sounds a bit odd here because we're treating people with active metastatic disease. So it feels more like we're talking about preventing outgrowth of subclinical or microscopic disease, which I would assume would mean if you screen those patients, we wouldn't see it because the area is small enough that the blood tumor barrier is still intact. So it's not enhancing. It does raise a question of, do drugs have to get there? Do they just have to control the systemic disease? It seems a difficult thing to study.
I think so. And I think that part of it is just in terms of the way our clinical trials are designed, it's hard to get excited from a purely clinical perspective in patients who don't have brain mets to do MRI scans on a regular basis timed with the CAT scans. But that's really, from a scientific standpoint, the best way to really understand whether drugs prevent brain metastases because we know that if we wait for symptomatic brain mets, that significantly underestimates the true prevalence of brain mets. So I think the best we can do in most trials now is to look at the appearance of symptomatic brain mets, since that's how most of the brain mets are discovered, and to try to compare arms. And I do think that's an interesting secondary endpoint to include in large randomized trials, just to get an understanding to some extent of whether various different interventions might delay that onset of symptomatic CNS disease.
So I want to take you to some of the treatment questions that come up, whether patients come to attention because of symptoms or because someone went looking for trouble. When you find it, you have to figure out what to do about it. So when it's first diagnosis of CNS metastases, how do you think through, do I call the neurosurgeon? Do I call a radiation oncologist? Do I just switch their systemic therapy to something that you've shown has activity? What are the considerations that you're running through?
That's exactly right. I think about each of the disciplines and what their role might be. So the first and usually most straightforward question is there willful surgery? That's generally the patients who have a large symptomatic lesion. It could be a single lesion. There might be other lesions, but if there's a dominant lesion that's clearly causing acute problems, that would be a reason to involve neurosurgery for an assessment. And surgery nowadays is so amazing. Like patients recover unbelievably quickly for the most part. So I definitely do consider that often as my first branch point. And then next, the question is radiation the optimal option in the situation, or should we just switch systemic therapy? And I will say I don't make these decisions in a vacuum. Like I do send patients to radiation oncology and then we discuss it as a team. But some of the considerations are if somebody has a significant disease burden extracranially that's progressing, and the intracranial disease burden is not dramatic, and I'm going to have to switch their systemic therapy anyways, I will often switch the systemic therapy and just watch the brain. So, for example, somebody who's on HP maintenance and has dramatic liver progression, we're going to switch them to TDXT anyways, and we know that it has CNS activity, so I might just watch that patient and do a short interval scan. For a patient who has stable extracranial disease, then it really becomes if there's a relatively straightforward SRS option and this is their first presentation, that's usually what I will do first is SRS and then leave the systemic therapy alone. Because many patients actually, we don't have great data, but the data suggests that patients probably get somewhere in the 6 to 12 month range of additional time on their initial systemic therapy before we have to make another switch. And some patients have even much longer than that. If a patient has enough disease where we're really thinking about whole brain radiation and they have a good systemic option, like they've not received TDXD before, they've not received tucatinib before, in those patients, I will discuss that whole brain would still be considered at this point our standard of care, but that I think it's reasonable to consider a systemic option to try to defer the need for whole brain, just given our knowledge of the long term toxicity of whole brain and the fact that the HER2 positive patients are the most likely to see that long term toxicity because they're the most likely subtype to actually survive out to that time point.
So I think the group that we all fear the most and struggle the most with are the ones with isolated CNS progression. I can think of several patients in my practice who never had systemic progression from the day I first gave them trastuzumab for their metastatic disease. And their only problem was continued progression of CNS metastasis. There were initial guidelines saying thou shalt leave the systemic therapy alone and use local modalities. But those guidelines were really before we understood the activity of some of the systemic treatment options. Have the guidelines changed?
So I think the guidelines are evolving. And I think that part of the evolution has to do with more clear delineation between initial management and subsequent management. So, what do you do when the patient first presents with their brain metastases? Let's say they have isolated CNS disease. Most people still today would give radiation if there's a SRS kind of option. But what happens when the patient progresses again in the CNS? Do we keep radiating them 10 serial times, or do we start trying to add in systemic therapy? And the other concept that was coming more to the forefront is this concept of brain metastasis velocity. This was developed in the radiation oncology literature, but I think is very useful. Essentially, what the investigators did is they looked at patients who received SRS, and then they looked at how many lesions occurred over the first year after the SRS. And not surprisingly, patients who had more lesions occur ultimately needed whole brain at higher rates than patients who had less lesions occur in that same time frame. So I borrow that as I think about systemic therapy. So a patient who has their second brain met progression event 18 months after initial SRS and they have two lesions that are very small, I will often just send them for more radiation, to be honest, because systemic therapy also has toxicity. But that patient who has these repetitive events, every other scan or every scan, you start seeing new lesions, it just seems unworthwhile to me to chase them with SRS. And I think systemic therapy there, to me, makes the most sense. People often ask for prospective trials and randomized trials, but the devil's in the detail. I mean, there's so many different ways people can present. There's all these different scenarios. And so I think that for some of these questions, we're ultimately going to have to rely on common sense and expert consensus. And real-world data, and I don't think that that's a terrible thing to do.
Early in my career, if you had brain mets, if it wasn't surgically resectable, you got whole brain radiation. And I think because survival in general was so much less, we didn't worry much about the toxicity of whole brain radiation in adults. I think we've clearly seen since then that from a cognitive standpoint, whole brain radiation is not a good thing to do to an adult. And I wonder sometimes if we've almost become so fearful of it that we try to do everything we possibly can, even when the scan and the tempo of the disease is telling us that's what's going to be needed. Do we have better data on what the cognitive effects in adults are and over what time course we start to see those effects?
Yeah, you can actually see the effects quite early on. So, in some of the trials, like the trials looking at memantine or the trials looking at hippocampal avoidant whole brain radiation, even at 3, 6 month time points, you do see differences in neurocognitive test performance between the neurocognitive sparing approach, whether it's memantine or hippocampal avoidance, and the other approach. And the same with the whole brain versus SRS studies. You can start seeing effects relatively early. But the profound effects that we see tend to happen late, right? And so those patients who just can't function anymore. I've seen people who have been confined to a wheelchair because they have gait instability that is so profound, and their ability to function in an independent way is completely decimated by the late effects of whole brain. And so I have seen enough of that that it obviously gives me pause. But those are effects that are years out. And so, again, like that patient who has very rapid tempo of disease, where you think that their survival is likely going to be a year or less. Yes, there is short term toxicity with whole brain. Yes, we have to take it seriously, but there's also cognitive toxicity from CNS progression. And so we have to balance that. And that patient who has the rapid tempo progression of disease and doesn't have great systemic options, you have to control their CNS disease. That will also help their cognitive functions, at least in the short term. And so we're really starting to think about what is the life expectancy of that patient, and it really affects my enthusiasm or not for pursuing whole brain radiation.
In our last minute or so, Dr. Lynn, we haven't talked about leptomeningeal disease, which happens a lot when we talk about CNS metastasis. We tend to leave that bad boy off to the side. Have we made any progress in managing those patients with leptomeningeal disease?
We actually have made some progress, which is kind of amazing to say because for many years the answer was no. So, obviously, from a local therapy standpoint, there's this really interesting data for proton cranospinal radiation, and the role of that is still being really defined, and we're not totally sure where to use it, but it does represent an improvement over the options that we had. And then systemically, we have a number of different options. So there have been now several phase 2 trials of intrathecal trastuzumab in patients with HER2-positive LMD. And probably the most solid endpoint for LMD trials is overall survival, since the response criteria are constantly being debated. But the overall survival in the IT trastuzumab trials was, between 8 to 10 months, which even in HER2-positive LMD patients, if you look at real-world data, most of the studies show survivals of less than 6 months. So there's something there. There were responses. And then if we look at the catnip capecitabine trastuzumab regimen, that was looked at in a TBCRC study that was presented actually at ASCO earlier this year. And that study not only showed partial responses by the Zerano LMD criteria, but also they asked patients to do quality of life assessments, and the physicians actually rated their symptoms and signs. And they actually showed not only stabilization, but actually pretty dramatic improvement in quality of life and symptoms with this regimen, and a survival in the 10-month range from the time of study entry. And now we have actually some data for TDXD even. And so our center collaborated with Duke, and we identified a small number of patients, like 8 patients with HER2-positive leptomeningeal disease. But in fact, many of those patients actually did achieve clinical benefit. I have some patients been on for more than 2 years with leptomeningeal disease and positive cytology and good disease control. So I would not have expected that, but we are actually seeing something quite interesting in that population as well. So I do think that there's starting to be some movement, and at least we can offer patients some options that were previously not available.
Thank you all for joining us. Today, we've been talking with Dr. Nancy Lin about CNS metastasis in patients with HER2-positive disease. This is an area where we've made huge progress and really requires a multidisciplinary approach involving the medical oncologist, radiation oncologist, and at least for some patients, neurosurgery. This is also an area where we're going to continue to think about surveillance, and perhaps that may have a role for our patients in the future. Please take a moment to download the Medscape app to listen and subscribe to this and other podcast series on breast cancer and HER2. And Dr. Lin, thank you for joining me.
Thank you for having me.
This is Dr. Kathy Miller for the Medscape In Discussion podcast.
Thanks for listening to Medscape's In Discussion Breast Cancer and HER2 podcast series with our host, Dr. Kathy Miller. Be sure to look for more In Discussion episodes wherever you get your podcasts. Check out Medscape.com or the Medscape app for show notes, links, and more information on breast cancer and HER2.